Hello and welcome to this session of Maritime Medicine in which we discuss headache. By the end of this session, you'll be able to define headache, identify at least 3 common and generally benign causes of headache, identify at least 4 serious causes of headache, and identify at least 5 red flags for serious headache. So a headache is a patient's perception of pain somewhere above the midface. If you draw a line at about the level of the bottom to the middle of the nose up, people would describe pain above that as headache generally. They might describe pain below that as facial pain, and they might include forehead and eye pain as facial pain, but generally those get lumped into the category of headache. It can be very, very difficult to localize where this pain is coming from. The brain has no pain receptors, so if the brain itself is injured or irritated, it doesn't perceive the pain. The meninges surrounding the brain, those do perceive pain, and they'll also perceive mass and stretching. The bones of the skull have pain receptors, and the scalp itself, the muscles, the skin, those all have pain receptors as well. So what we perceive as pain in our head may very well be pain around our head, in the meninges, the bone, the scalps. Typically, headaches are benign. They're a very common complaint. People will get headaches for any number of reasons that really aren't life-threatening or serious, but it can be very difficult to sort out what's serious or not. So it's important to know red flags of headache so that you can get at least a general idea, if you see them, that you need to look more closely to make sure nothing bad's going on. So typical red flags for severe disease: a headache that's sudden onset and immediately within an hour at its worst. And in your environment, the worst headache of their life might also be an important red flag for you. In the emergency department, people are there because their headaches are bad, so they often will describe any headache as the worst headache of their life. If they say that, pay a bit more attention, but on the other hand, in and of itself, it doesn't necessarily mean anything. But if it's sudden onset and immediately at its worst, within an hour or so, that's a bad sign. A headache associated with fever is concerning. A headache that's worse when the patient lays down, particularly if it's better in the evening and worse when they first wake up in the morning. Any headache associated with focal neurologic findings, so weakness or loss of sensation, facial droop, slurred speech, those are all concerning findings. And any headache associated with a seizure, unless the patient has a history of seizures, but that's not typically going to be the population that you're dealing with. So tension headaches are going to be some of the most common. They're caused by tension of the scalp and the neck muscles. Those muscles all contract. It's a pulling, tight sensation, generalized, gradual onset headache. Usually it gets worse over the course of the day. Their neck may feel sore to them as well. The muscles of the neck and the scalp may be tender when they rub on them, or they may feel better if they massage them. And these patients won't have any of the red flags we just discussed. So the treatment is to rest. Scalp and neck massage can help. Analgesics like acetaminophen and nonsteroidals may help. And topical lidocaine as a numbing medicine at the base of the skull, just lateral to the midline. And if you look at the picture in the middle, you're looking at a picture of the greater occipital nerve, that yellow structure sticking out from the middle of the skull, in this case just to the patient's right of the midline. You're looking at the back of the skull here. If you put some lidocaine over there, it can break the muscle spasm as it absorbs, and it can help to turn off that nerve so it's not perceiving the pain from the muscle spasm. So that would be a consideration as well. Of course, you're going to talk to medical control before you administer that. Migraine headaches are a very common headache syndrome, and a lot of people will tell you they have migraine headaches. And what they mean is they get bad or uncomfortable headaches, but they've never been formally diagnosed as having migraine headaches. And often, they don't actually have migraine headaches by the true formal definition. They just have bad tension headaches, or they have some other type of headache syndrome, cluster headaches, whatever it may be. People assume that migraine headache is medical talk for bad headache, and that's not the case. Migraine headaches are a very specific type of headache syndrome. So the characteristic or classic presentation is a headache that's on one side of the head, often described as being behind the eyes, often described as a pressure sensation, associated with photophobia, which means that light makes the headache worse. Light bothers the eyes and makes the headache worse. Phonophobia, sound makes the headache worse. They may have what's called an aura, which is a visual perception change that it precedes the headache by an hour or so, and they may get what are called scotoma, or flashing lights in the visual field. There's no headache when they're having those symptoms, but that's a warning for them that they're going to develop the headache. And then when the headache starts, those should go away. They almost all have nausea, and they may have severe vomiting, which may be part of why they're coming to see you. They can't control their vomiting. And they may have neurologic symptoms. I've taken care of patients who have migraine headache, but who also get paralysis on half their body, so it looks like they're having a stroke. And if they've always had these symptoms and they're exactly the same as they are every time they get the migraine, you're less worried, although you're still concerned, because I have in fact taken care of a patient whose migraine presentation was right-sided paralysis that would gradually fade into weakness associated with his headache, who also had on MRI proof of having had a stroke that affected the right side of his body during one of his episodes. And people with migraine seem to be at increased risk of stroke. So it can be very difficult to differentiate between an acute stroke that's occurring while they have a migraine or their classic migraine with their focal neurologic symptoms. So talk to medical control and be conservative about considering evacuation. These patients shouldn't have any other red flags. You need to confirm that they've had a history of migraines in the past. You're not going to make that diagnosis. Typically, they're going to come to you because they tried whatever medications they usually use to stop their headaches, and they didn't work. So now they've got this ongoing headache, their own medications aren't helping, or they vomited them up. So you need to talk to medical control. What we give in the emergency department to take care of these patients, we give them anti-nausea medications, which for reasons we don't understand seem to also have an anti-migraine and anti-headache effect in general. And we'll often give them IV, but they can be given orally as well, or IM. Oral non-narcotics like ibuprofen or acetaminophen, and they may tell you those haven't worked yet for them, but you're using them in combination with some other medications. If there's been significant vomiting or you have any reason to think they're dehydrated, give them IV fluids. If they have a headache that's lasted longer than 24 hours, talk to medical control about giving them some IV steroids, IV Decadron, between 4 and 10 milligrams. And while this doesn't help the headache they have now, it's been shown to likely decrease the incidence of recurrent headaches in the next 72 hours. Give them diphenhydramine, Benadryl. That seems to help some with the headache itself. It also makes them sleepy. And sleep is a huge part of getting over a migraine. If you can get these people to fall asleep, when they wake up, they typically feel much better. If you cannot get the headache under control, medical control may order narcotics. There are some people with headache, migraine syndromes who end up needing narcotics. We've really moved away from that. That was sort of the standard 20 years ago. We really try not to do that now. And if you're getting to narcotics, you need to think, geez, did I make the wrong diagnosis here? Dehydration is something else that you're going to see a lot of. It may be caused by blood vessels. The headache may be caused by blood vessel spasming, or it may just be that we're not getting enough blood flow, that the blood is thicker. We're not positive why people with dehydration get headaches, but it's very, very common. They'll have other symptoms of dehydration. Their urine will be darker. They'll feel lightheaded when they stand up. They'll have the umbles, fumble, mumble, stumble, grumble, and tumble. They'll have some nausea and vomiting, and they should have no red flag findings. So if you think somebody's is dehydrated and they also have a headache, by treating the dehydration, you treat the headache. Talk to medical control, anti-nausea medications, oral fluids if they'll tolerate them, if not, IV fluids. Now, bad things can cause headache too. So subarachnoid hemorrhage is one of those. It's bleeding into the space in your brain between the meninges, the arachnoid and the pia mater meninges. And so typically you have a bulging in the walls of one of your arteries called an arterial aneurysm, and that ruptures. Sometimes venous aneurysms or just veins themselves can leak into that space, because that is a space with a pretty good venous and arterial supply, and the blood distributes throughout the brain between those layers. And you can see on this CT scan the arrows pointing to the aneurysm, but the white tracing around the dark gray, particularly you see a circle, what almost looks like a a little person in the center there with two legs going down and long toes and two arms and a real skinny head going anterior. That's blood tracking through the spaces that the meninges cover on the brain. And if this is arterial, it's life-threatening and needs to be diagnosed and addressed immediately. So the presentation of a subarachnoid hemorrhage is acute severe headache that's almost immediately at its worst. Within an hour or two of the onset, this headache should absolutely be at its worst. The blood tracks down the meninges along the spinal cord, so they'll typically have neck pain and spasm. And if it's severe, they may have altered mental status. In fact, that may be the presentation, is they suddenly become unresponsive from the amount of bleeding they have. They may be hypertensive. Typically that's more of a pain response, but if the bleeding gets significant enough, it can also be part of the Cushing's reflex to try to push more blood into the brain to increase the cerebral perfusion pressure. They may have altered mental status. They may just be very uncomfortable. It's unlikely to find focal neurologic findings, so you don't find weakness in just one hand or on the left side of the body. And if you look at this picture, the CT scan again, you can see the blood is sort of spread everywhere, so there's no one particular area of the brain that's being affected, so you're unlikely to have just focal neurologic findings from one particular area. Treatment: stabilize the airway, stabilize breathing if they're unresponsive. This can lead to cardiac arrest. Figure out your neurologic status and continue to track that. Expose them, make sure there's no signs of any trauma or other findings. Look for other scene clues that might explain something else as being the cause. Talk to medical control. You're going to need to get them comfortable. These people are miserable, and you're going to need to evacuate them immediately because they need a neurosurgeon to fix this problem. In hemorrhagic stroke, you can get bleeding into the brain tissue. It can be from either arteries or veins. And these patients often don't have a headache, but sometimes they will. And so you need to be able to examine them and consider this. It's typically indistinguishable from an ischemic stroke without a CAT scan. So they may present looking exactly like a patient who has an ischemic stroke, and it's a life-threatening emergency. And those CAT scans, those area of white in there, that's bleeding into the brain tissue, and that's occurring over time. So A is early on, there's a little bit of blood in the tissue, B, more blood, and C, blood, and there's what's called edema around the tissue, so swelling that's not bleeding into the tissue surrounding the area of bleeding, and that's compressing the brain. The presentation will typically be of altered mental status, could be confusion, slow speech. They may have a headache, and they may have weakness, and they may describe it as general weakness, or they may have lateralizing weakness. Your findings typically will be of an altered mental status and focal neurologic findings, because the bleeding's in a specific part of the brain, so it's going to affect specific brain functions. But because it's affected by swelling, and the bleeding may decompress itself a bit into the spaces where the cerebrospinal fluid is, the findings may wax and wane and generalize, and they may be hypertensive, either as the cause of the bleed or as they try to compensate for this increasing intracranial pressure. Again, you won't be able to distinguish this from an ischemic stroke. You may not be able to distinguish this from a subarachnoid hemorrhage. Typically the headache's not thunderclap the way it is in a subarachnoid hemorrhage, but your treatment is the same. Any bleeding, control it, and then airway, breathing, CPR if needed, contact medical control. You'll put in an IV and you'll evacuate these patients. You're going to be a little reluctant to give them any pain medication through the IV because you don't want to dramatically change their mental status. All the patients I've seen with these sort of bleeds tend to have some degree of altered mental status to start with, and it can be very confusing if you're giving them narcotics to determine whether something has changed in the bleed itself or if it's because of the narcotics. Meningitis is an infection in the cerebrospinal fluid and of the meninges themselves, those thin layers around the brain, and they're systemic as well. You don't just have an infection of the brain and the meninges, it's in the bloodstream, it goes throughout the body. Lots of things can do it, bacteria, viruses, fungus, and you increase the intracranial pressure from swelling and edema, you decrease cerebrospinal fluid production and actually can plug up the flow of cerebrospinal fluid, which increases pressure inside the brain swells, and the patient gets symptoms from all of that. Common pathogens from the bacteria, Streptococcus pneumoniae is the most common bacterial cause. That's typically seen in adults, and it's bad. It's not an infection you want to have. Neisseria meningitidis is responsible for most of the meningitis in children and young adults, 59%, although it's rapidly decreasing because it's vaccine preventable, and this is now one of the childhood, early adolescent vaccines that's routinely given. This type of meningitis is the one that classically occurs in a college setting or shipboard or a prison or a army barrack or military barracks where there's a lot of younger people close together and it's spread by droplet. And then any number of viruses, including the human herpes virus too, which is the one that gives you cold sores, can cause meningitis as well. And in fact, people who get the herpes meningitis, typically it comes from their own herpes virus that's living in their nerves, the one that would otherwise give them a cold sore. It just kind of moves retrograde and gives them a meningitis instead. So your presentation, your symptoms of a headache that's persistent even when you treat their fever. The fever goes away, they still have a headache. It may improve some, but typically it's there. They get neck spasm or stiffness called meningismus, and it's not just that their neck hurts to move, it's that there's so much irritation of the meninges that it actually puts the muscles into spasm and the neck almost becomes locked. You can't flex it or extend it. Nausea and vomiting, confusion, they may be bothered by light. And the findings are fever, that meningismus, that neck stiffness, and they may have a rash. You look at this patient here, and you see those small purple dots on the abdomen. That's petechiae, and that's a sort of classic finding with meningococcal meningitis, the Neisseria meningitidis meningitis. This was a patient who actually came in confused and combative, and it was thought that he had, by EMS and the police, that he'd overdosed on drugs, and when we cut his clothes off to evaluate him, that is, did the exposure part of A, B, C, D, E, F, he was covered with these petechiae, and we immediately knew that his problem was meningitis. So this is where protecting yourself is a huge deal. This is highly communicable. If it's meningococcal meningitis, it's spread by droplet. If someone's got a fever and a headache, you need to be wearing a mask. You resuscitate them. You talk to medical control. You'll give them IV ceftriaxone, 2 grams, IM if you can't get an IV. IV normal saline. If the pain's severe and they don't have altered mental status, IV pain medication. If this is, if you think it's meningococcal meningitis, you're talking to medical control and they've got the petechial rash, they may order you to give steroids, which protects them from hearing loss, and they need to be evacuated. You do not want this person remaining shipboard. And then if you didn't have your mask on when you initially saw them, you're going to end up needing to take prophylactic medication to make sure that you don't develop meningitis. So you talk to medical control and they'll walk you through what you have shipboard that you can take. Now, lots of other infectious illness can cause headache without it being meningitis. So viral syndromes, if you've ever felt really run down, you've had runny nose, muscle aches, you usually get the headache with that. Influenza, it's a really bad cold with cough is the presentation, but they've got the flu, and they also have a headache. And then lots of other infectious diseases, particularly some of the tropical diseases, can cause a headache without there truly being meningitis. So talk to medical control. This can be really hard to sort out what's going on if you've got a patient with a fever and a headache, and you're going to tend towards being conservative in these patients and treating them with prophylactic antibiotics, or empiric antibiotics actually, and which means you're treating but you don't know what you're treating, and planning to evacuate them. Brain tumors, a cancer mass growing in the brain can cause headache, and again the brain itself doesn't have pain receptors, so you don't get the headache until it starts to irritate the meninges, or it gets big enough to block outflow of fluid, the cerebrospinal fluid, and causes pressure inside the skull. oftentimes it'll present other symptoms beforehand, focal neurologic symptoms, because it's growing in a specific area. And here's an MRI, and you can see a tumor. That's the white area with the arrow on it. And then the darker gray around it is swelling or edema that's affecting the tissues, and then the lighter gray is the rest of the brain. So your presentation typically is gradually worsening headache, and they may describe weakness or clumsiness. They may say that their foot's starting to drag, they're tripping and falling a lot more, they've got weakness in their right hand, and they're fumbling with things, so focal neurologic findings. And a headache that tends to be worse when they first awaken in the morning and then goes away or gets better at night, or gets worse if they lay down, but if they stand up it feels better. And that's because when they're laying flat, the tumor is blocking the flow of cerebrospinal fluid or decreasing it, and so it increases the pressure in the brain, and the meninges get stretched. When they stand up, gravity helps to drain some of the fluid, and they feel better. On exam, they may have focal neurologic deficits. They may have altered mental status, like confusion. They may present with a seizure. Particularly in kids, this is unfortunately how oftentimes these tumors present. And you really can't distinguish it from other bad things, so you're going to talk to medical control, and you'll plan to evacuate these patients. Please complete any associated knowledge reviews, and if you have any questions, don't hesitate to contact your professor or your instructor. Thank you very much.